Question 1. A 68-year-old male presents with sudden onset of severe, tearing chest pain radiating to his back. He is diaphoretic, pale, and has a significant difference in blood pressure between his left arm, 160/90 mmHg, and right arm, 110/60 mmHg. His ECG shows sinus tachycardia with no ST segment elevation. Which of the following is the most critical immediate intervention beyond basic life support and oxygen? A. Administer aspirin 325 mg chewed. B. Prepare for rapid transport to a cardiac catheterization lab. C. Establish 2 large-bore IVs and prepare for fluid resuscitation. D. Position the patient comfortably, avoiding any maneuvers that increase blood pressure. Answer: D. Position the patient comfortably, avoiding any maneuvers that increase blood pressure. This question describes a classic presentation of an aortic dissection, a life-threatening emergency. The key clues are the sudden onset of severe, tearing chest pain radiating to his back and the significant difference in blood pressure between his left and right arms. While fluid resuscitation and transport are important, the immediate priority for a suspected aortic dissection is to prevent further dissection by minimizing stress on the aorta, which includes careful handling and avoiding any actions that might increase blood pressure. Administering aspirin is contraindicated as it can worsen bleeding in an aortic dissection, and cardiac catheterization is not the primary treatment for this condition. In these cases, it's vital to handle the patient gently and avoid any unnecessary exertion or agitation. Question 2. You are managing a 28-year-old male involved in a high-speed motor vehicle collision. He is unconscious, apneic, and pulseless. Your partner has begun chest compressions. You attempt to open the airway using a jaw thrust maneuver, but despite this, the patient's airway remains obstructed, and you cannot ventilate with a BVM. Which of the following is the most appropriate next step? A. Insert an oropharyngeal airway, OPA, and reattempt ventilation. B. Perform a needle cricothyrotomy. C. Reposition the head while maintaining C-spine precautions and reattempt jaw thrust. D. Consider a supraglottic airway device, such as an iGel or King LT, if trained and authorized. Answer: D. Consider a supraglottic airway device, such as an iGel or King LT, if trained and authorized. This scenario presents a critical airway obstruction in a trauma patient where initial airway maneuvers have failed. The concept tested is the rapid management of a difficult or failed airway in the field. When a jaw thrust fails to open the airway sufficiently for BVM ventilation, and given the patient is apneic and pulseless, indicating immediate need for ventilation, an OPA is unlikely to solve a persistent obstruction if the jaw thrust was already attempted correctly. A needle cricothyrotomy is a more advanced and invasive procedure typically reserved for can't intubate, can't ventilate scenarios, often after less invasive advanced airway attempts. The most appropriate rapid next step after failed manual maneuvers is to deploy an advanced airway adjunct that can bypass the upper airway obstruction, such as a supraglottic airway device. For example, inserting a King LT can establish a seal in the esophagus, allowing ventilation of the lungs when other methods fail. Always remember that immediate effective ventilation is paramount in cardiac arrest, and moving quickly to a definitive airway is key when basic methods fail. Question 3. A 4-year-old child presents with a sudden onset of barking cough, stridor, and difficulty breathing. The child is afebrile and has no history of recent illness. The parents state it began after playing with small toys. You note mild retractions and clear lung sounds bilaterally. What is the most likely cause of these findings? A. Croup. B. Epiglottitis. C. Foreign body aspiration. D. Bronchiolitis. Answer: C. Foreign body aspiration. This question tests your ability to differentiate common pediatric respiratory emergencies based on key signs and symptoms. The crucial clues are the sudden onset, barking cough, stridor, afebrile, and the history of playing with small toys. While croup, laryngotracheobronchitis, typically causes a barking cough and stridor, it usually follows a viral illness and may involve a fever. Epiglottitis is characterized by sudden onset of stridor, high fever, and drooling, without a cough. Bronchiolitis is more common in infants and presents with wheezing and crackles after a viral prodrome. A foreign body aspiration uniquely presents with sudden onset of symptoms, especially stridor and cough, often without fever, following a potential choking event. For example, a child aspirating a small toy might present exactly like this, requiring immediate assessment for airway obstruction. Always consider foreign body aspiration in a child with sudden respiratory distress, especially if they were recently playing with small objects. Question 4. You are assessing a 55-year-old male who collapsed at a community center. He is unresponsive, pulseless, and apneic. Bystanders report he suddenly clutched his chest before collapsing. Your ECG shows ventricular fibrillation, VF. After delivering your first defibrillation, what is your immediate next action according to current American Heart Association, AHA, guidelines? A. Check for a pulse. B. Resume chest compressions immediately. C. Administer 1 mg of epinephrine 4. D. Prepare for a second defibrillation. Answer: B. Resume chest compressions immediately. This question focuses on the critical sequence of actions during cardiac arrest management, specifically after defibrillation for ventricular fibrillation, VF. According to current AHA guidelines, after delivering a shock for VF or pulseless ventricular tachycardia, private, the most important immediate action is to resume high-quality chest compressions without delay. There is no pulse check after the first shock. Compressions should be restarted for 2 minutes or 5 cycles of CPR before the rhythm is reassessed. Administering epinephrine or preparing for a second shock come later in the algorithm if VF persists after the first round of CPR. For example, if you just shocked a patient, your hands should be back on the chest beginning compressions within seconds. This rapid return to compressions minimizes hands-off time and maintains vital blood flow to the brain and heart. Question 5. A 35-year-old female presents with acute onset of severe right lower quadrant abdominal pain, nausea, and vomiting. Her last menstrual period was 8 weeks ago. She is pale, diaphoretic, and her blood pressure is 90/60 mmHg, heart rate 110 bpm, respiratory rate 22 bpm. On examination, she has significant tenderness to palpation in the right lower quadrant with rebound tenderness. What is the most important field intervention beyond oxygen and transport? A. Administer analgesics for pain relief. B. Rapidly administer a 500 ml 4 fluid bolus. C. Perform a detailed gynecological history. D. Assist her into a comfortable position. Answer: B. Rapidly administer a 500 ml 4 fluid bolus. This scenario describes a patient presenting with classic signs and symptoms of an ectopic pregnancy rupture, a life-threatening cause of hemorrhagic shock. The key indicators are the acute onset of severe right lower quadrant abdominal pain, last menstrual period 8 weeks ago, and signs of hypovolemic shock like pale, diaphoretic, and vital signs of BP 90/60 millimeter of mercury, HR 110 bpm. While pain relief and positioning are important, the immediate priority for a patient in suspected hemorrhagic shock is volume resuscitation. A rapid 4 fluid bolus, typically 500 ml for adults, helps support blood pressure and perfusion until definitive surgical care can be provided. A detailed gynecological history is important for diagnosis but secondary to life-saving interventions. For instance, in a patient bleeding internally, Fluid is crucial to maintain circulating volume. Always prioritize treating shock over obtaining exhaustive history when immediate life threats are present. Question 6. A 6-year-old child presents after accidentally ingesting an unknown quantity of their grandparents' cardiac medication. The child is now lethargic, has a heart rate of 48 bpm, and a blood pressure of 70/40 mmHg. Initial interventions include oxygen and ventilatory support as needed. What is the most appropriate medication to consider for this presentation, given the likely overdose? A. Atropine. B. Epinephrine. C. Naloxone. D. Activated charcoal. Answer: A. Atropine. This question tests your knowledge of specific pharmacological interventions for pediatric poisoning based on the patient's presentation. The crucial clues are the ingestion of grandparents' cardiac medication and the resulting bradycardia, HR 48 bpm, and hypotension, BP 70/40 mm of mercury. Many cardiac medications, especially beta blockers or calcium channel blockers, can cause severe bradycardia and hypotension. While activated charcoal can be considered for some ingestions, it's not a primary medication to reverse the immediate life-threatening physiological effects. Naloxone is for opioid overdose, and epinephrine is typically for anaphylaxis or severe shock with normal or fast heart rates. Atropine is a parasympatholytic agent specifically indicated for symptomatic bradycardia, which directly addresses the child's dangerously slow heart rate caused by cardiac medication overdose. For example, if a child ingests a beta blocker, atropine helps block the effects that slow the heart. Remember to treat the life-threatening symptoms first and foremost in toxicology emergencies. Question 7. You are assessing a 45-year-old male found unresponsive at a construction site. He has pinpoint pupils, is apneic, and has a weak, thready pulse of 40 bpm. There are no signs of trauma. Your partner is attempting to ventilate with a BVM, but you note poor chest rise despite an apparently good seal. What is the most immediate concern for effective ventilation in this patient? A. Tongue obstruction. B. Laryngospasm. C. Airway swelling. D. Gastric distension from BVM ventilations. Answer: A. Tongue obstruction. This question describes a patient with classic signs of opioid overdose, unresponsive, pinpoint pupils, apnea, bradycardia, and introduces a common challenge in airway management, ineffective BVM ventilation despite a seemingly good seal. While laryngospasm and airway swelling can occur, the most common and immediate cause of airway obstruction in an unresponsive, apneic patient without trauma is the tongue falling back and obstructing the pharynx. This is especially true if initial attempts at ventilation are difficult. Gastric distension is a consequence of poor ventilation, not the initial cause of obstruction. For example, if a patient's tongue is blocking the airway, you might hear gurgling or simply get no air movement. Performing a jaw thrust or head tilt chin lift and inserting an oral or nasal airway is critical to overcome this, and it's the first thing to rule out when BVM ventilation is difficult. Always ensure proper airway positioning and adjunct use before considering more complex causes of ventilation failure. Question 8. A 22-year-old female with a history of asthma is in severe respiratory distress. She is sitting upright, using accessory muscles to breathe, speaking in one-word sentences, and has widespread wheezing bilaterally. Her SpO2 is 88% on room air. She states she used her albuterol inhaler several times with no relief. What is the most appropriate initial pharmacological intervention? A. High-flow oxygen via non-rebreather mask. B. Nebulized albuterol and ipratropium. C. Subcutaneous epinephrine. D. Intravenous corticosteroids. Answer: B. Nebulized albuterol and ipratropium. This patient is experiencing a severe asthma exacerbation, indicated by severe respiratory distress, accessory muscle use, speaking in one-word sentences, and an SpO2 of 88%. While high-flow oxygen is essential supportive care, it is not a pharmacological intervention to reverse bronchospasm. Subcutaneous epinephrine is typically reserved for anaphylaxis or severe asthma refractory to inhaled bronchodilators in the hospital setting, not as a first-line medication for bronchospasm. Intravenous corticosteroids are important but have a delayed onset of action. The most appropriate and immediate pharmacological intervention for severe bronchospasm is nebulized albuterol, a short-acting beta agonist, combined with ipratropium, an anticholinergic, as this combination provides synergistic bronchodilation and is a standard treatment for acute severe asthma. For instance, this combined therapy effectively relaxes the constricted airways, allowing the patient to breathe more easily. Always remember to administer bronchodilators promptly in severe asthma. Question 9. You are managing a 72-year-old male who suffered a ground-level fall. He complains of left hip pain and has a shortened, externally rotated left leg. He is conscious and alert. His vital signs are stable, but he has significant pain. Which of the following is the most appropriate initial management for his suspected injury? A. Attempt to reduce the dislocation manually. B. Apply gentle traction to the leg to relieve pain. C. Immobilize the leg in the position found using a scoop stretcher or full-body vacuum mattress. D. Administer a large bolus of intravenous fluids to prevent shock. Answer: C. Immobilize the leg in the position found using a scoop stretcher or full-body vacuum mattress. This question describes a classic presentation of a hip fracture, shortened, externally rotated leg after a fall, and tests the proper pre-hospital management of this type of injury. The concept is immobilization of suspected fractures to prevent further injury, reduce pain, and minimize complications. Attempting to reduce the dislocation manually is outside the scope of pre-hospital care for suspected hip fractures and could cause significant harm. Applying gentle traction might be done in some settings for specific long bone fractures, but for a hip fracture, the primary goal is rigid immobilization to prevent movement at the fracture site. Administering a large bolus of 4 fluids is not indicated unless signs of shock are present, which this patient does not exhibit. The most appropriate initial management is to immobilize the leg in the position found, often achieved effectively with devices like a scoop stretcher or full-body vacuum mattress, to minimize movement and pain during transport. For example, simply moving the patient onto a backboard without proper immobilization could worsen the injury. Always secure the injury in the position found unless specific protocol dictates otherwise. Question 10. A 30-year-old male is found unconscious in a cold environment. His core body temperature is measured at 89 degrees Fahrenheit 31.7 degrees Celsius. He has a weak carotid pulse of 30 bpm and is breathing shallowly at 6 breaths per minute. His skin is cold and mottled. Which of the following is the most critical intervention during initial management? A. Rapid rewarming with warm intravenous fluids and forced warm air. B. Aggressive chest compressions and early defibrillation for any dysrhythmia. C. Gentle handling and prevention of further heat loss. D. Insertion of an advanced airway and hyperventilation. Answer: C. Gentle handling and prevention of further heat loss. This question focuses on the unique considerations for managing severe hypothermia, particularly a patient with a core temperature below 90 degrees Fahrenheit 32 degrees Celsius. The concept is preventing rewarming shock or after drop and avoiding ventricular fibrillation in a profoundly hypothermic heart. Rapid rewarming and aggressive interventions like chest compressions or defibrillation can precipitate lethal arrhythmias, e.g., ventricular fibrillation, in a severely hypothermic patient whose heart is highly irritable. Hyperventilation is generally not indicated and can lead to complications. The most critical initial intervention is gentle handling to avoid stimulating the irritable myocardium, carefully moving the patient, and preventing any further heat loss by removing wet clothing and applying passive rewarming measures. For instance, even a slight bump can trigger a lethal rhythm. Remember, they're not dead until they're warm and dead. Question 11. You are treating a 42-year-old female with crushing substernal chest pain radiating to her left arm, diaphoresis, and nausea. Her ECG shows ST segment elevation in leads 2, 3, and AVF. Her blood pressure is 90/50 mmHg, heart rate 100 bpm. Which of the following medications is absolutely contraindicated in this patient? A. Aspirin. B. Oxygen. C. Nitroglycerin. D. Morphine. Answer: C. Nitroglycerin. This patient is presenting with an acute inferior myocardial infarction, MI, indicated by the ST segment elevation in leads 2, 3, and AVF. The crucial clue for the contraindication is the patient's hypotension, BP 90/50 mmHg, especially in the context of an inferior MI. Inferior MIs often involve the right ventricle, which is highly preload dependent. Nitroglycerin, a vasodilator, would further decrease preload, potentially leading to a drastic drop in blood pressure and worsening cardiac output, which can be fatal. Aspirin is indicated to prevent platelet aggregation, oxygen for hypoxia, and morphine for pain relief, none of which are contraindicated by hypotension alone in a STEMI unless other specific contraindications exist. For example, giving nitroglycerin to this patient could cause their blood pressure to plummet even further, leading to cardiogenic shock. Always remember to check blood pressure before administering nitroglycerin, particularly in inferior MIs. Question 12. A 78-year-old male complains of sudden onset of left-sided weakness and slurred speech. His symptoms started 2 hours ago. He has a history of atrial fibrillation and takes anticoagulants. On examination, his Glasgow Coma Scale, GCS, is 14, confused, and he has a significant left-sided facial droop and arm drift. His blood pressure is 180/95 mmHg. Which of the following is the most critical pre-hospital intervention for this patient? A. Administer aspirin 325 mg chewed. B. Rapid transport to a stroke-capable facility. C. Administer supplemental oxygen via nasal cannula. D. Initiate an intravenous infusion to lower blood pressure. Answer: B. Rapid transport to a stroke-capable facility. This patient is exhibiting clear signs and symptoms of an acute stroke, sudden onset left-sided weakness, slurred speech, facial droop, arm drift, within the critical time window for reperfusion therapies. The concept being tested is the importance of rapid recognition and transport for time-sensitive conditions like stroke. While oxygen might be beneficial if the patient is hypoxic, and aspirin might be considered in some stroke types, the priority for all stroke patients is rapid transport to a stroke-capable facility for definitive diagnosis, e.g., CT scan to differentiate ischemic from hemorrhagic stroke, and potential thrombolytic therapy. Administering aspirin is contraindicated if the stroke is hemorrhagic, and lowering blood pressure pre-hospital is generally not recommended unless it is critically high and causing other end organ damage, as it can worsen cerebral perfusion. For example, bypassing the closest hospital for a stroke center can make the difference between recovery and permanent disability. Always prioritize rapid transport to the most appropriate facility for stroke patients. Question 13. You are assessing a 16-year-old male who suffered a single stab wound to the left anterior chest. He is alert but anxious, complaining of severe shortness of breath. His skin is pale and cool, and you note unilateral diminished breath sounds on the left. His jugular veins are distended, and his trachea is deviated to the right. Which of the following conditions is most likely and requires immediate intervention? A. Open pneumothorax. B. Hemothorax. C. Cardiac tamponade. D. Tension pneumothorax. Answer: D. Tension pneumothorax. This question presents a critical traumatic injury scenario and tests your ability to identify and prioritize the management of a tension pneumothorax. The key indicators are the stab wound to the chest, severe shortness of breath, unilateral diminished breath sounds on the injured side, jugular vein distension, and, most critically, tracheal deviation away from the injured side. An open pneumothorax involves a sucking chest wound, a hemothorax involves blood in the pleural space, and cardiac tamponade involves fluid around the heart, but only a tension pneumothorax classically presents with all these signs of increasing intrathoracic pressure leading to mediastinal shift, tracheal deviation, and impaired venous return, JVD. For example, a tension pneumothorax rapidly compromises both breathing and circulation, requiring immediate needle decompression to save the patient's life. Always recognize the critical signs of a tension pneumothorax and prepare for immediate decompression. Question 14. A 60-year-old male with a history of congestive heart failure, CHF, calls 911 for sudden onset of severe shortness of breath. He is sitting upright, gasping for air, and you note bilateral crackles, rowels, heard throughout all lung fields. He has significant peripheral edema. His blood pressure is 160/90 mmHg, heart rate 110 bpm, respiratory rate 30 bpm. Which of the following medications is most appropriate to administer in the pre-hospital setting, assuming no contraindications? A. Albuterol nebulizer. B. Nitroglycerin sublingual or spray. C. Furosemide 4. D. Aspirin 325 mg chewed. Answer: B. Nitroglycerin sublingual or spray. This patient is experiencing acute decompensated congestive heart failure with pulmonary edema, characterized by severe shortness of breath, bilateral crackles, and peripheral edema, often with elevated blood pressure. The concept tested is the pre-hospital management of acute pulmonary edema. While all medications listed have a use, albuterol is for bronchospasm, not fluid overload. Furosemide is a diuretic that helps remove fluid but has a delayed onset of action and is less critical than immediate preload reduction. Aspirin is for cardiac ischemia, which is not the primary issue here. Nitroglycerin, a potent vasodilator, is the most appropriate and rapid-acting medication as it reduces both preload and afterload, helping to shift fluid from the lungs back into circulation and reduce the heart's workload. For example, giving nitroglycerin to this patient helps reduce the fluid in the lungs, feeling almost immediately. Always prioritize medications that rapidly address the underlying pathophysiology in acute CHF. Question 15. A 2-year-old child presents after being found unresponsive near an open container of drain cleaner. The child has significant drooling, difficulty breathing, and burns around the mouth and on the tongue. What is the most critical immediate airway management concern? A. Rapidly inserting an oral airway. B. Attempting to neutralize the caustic substance. C. Managing potential airway swelling and impending obstruction. D. Administering activated charcoal. Answer: C. Managing potential airway swelling and impending obstruction. This scenario describes a child who has ingested a caustic substance, such as drain cleaner, which presents an immediate and severe airway threat. The concept tested is the recognition and proactive management of potential airway compromise in a chemical ingestion. the significant drooling, difficulty breathing, and burns around the mouth and on the tongue are strong indicators of laryngeal and pharyngeal edema, which can rapidly lead to complete airway obstruction. While an oral airway might be considered, it could potentially traumatize already compromised tissues. Attempting to neutralize the substance is ineffective and can worsen damage or induce vomiting. Activated charcoal is contraindicated for caustic ingestions as it does not bind to them and can obscure endoscopic views. The most critical immediate concern is the high risk of rapid airway swelling and impending obstruction, requiring close monitoring and potentially early advanced airway management, such as intubation, before complete closure occurs. For example, the airway can swell shut within minutes or hours. Always prioritize careful airway assessment and proactive management in caustic ingestions. Question 16. You are called to a construction site for a 40-year-old male who has been impaled by a rebar through his left thigh. The rebar is approximately 2 feet long, protruding from both sides of his thigh. He is alert and conscious, with stable vital signs. There is minimal bleeding around the entry and exit wounds. What is the most appropriate action for managing the impaled object? A. Carefully remove the rebar to allow for direct pressure on the wound. B. Shorten the rebar by cutting it close to the skin on both sides. C. Stabilize the rebar in place with bulky dressings and secure it to prevent movement. D. Apply a tourniquet above the impalement to control potential bleeding. Answer: C. Stabilize the rebar in place with bulky dressings and secure it to prevent movement. This question addresses the critical principle of managing impaled objects in the pre-hospital setting. The concept tested is preventing further internal damage or hemorrhage by avoiding movement of the impaled object. The keywords are impaled, rebar, and stable vital signs, indicating that the immediate life threat is not active bleeding but potential damage from object movement. Removing the object is contraindicated as it can cause massive hemorrhage or further internal injury. Shortening the rebar by cutting it is generally beyond the scope of pre-hospital practice unless absolutely necessary for extrication and only if protocols and equipment allow, as it can cause vibration and movement. Applying a tourniquet is only indicated for severe, uncontrolled hemorrhage distal to the impalement, which is not described here. The most appropriate action is to stabilize the impaled object in the position found, using bulky dressings to prevent any movement during transport, which minimizes further tissue damage. For example, imagine the rebar moving inside the thigh every time the patient is bumped. Always stabilize impaled objects unless they obstruct the airway or prevent CPR. Question 17. A 65-year-old female with a history of COPD and diabetes presents with progressively worsening shortness of breath and a productive cough over the past 3 days. She is confused, her skin is warm and dry, and her vital signs are BP 80/50 mmHg, HR 120 BPM, RR 28 BPM, Temp 102.5 degrees Fahrenheit 39.2 degrees Celsius. Her SpO2 is 89% on 2 liters per minute nasal cannula. What is the most likely underlying condition causing her current presentation, and what is the immediate priority? A. Acute exacerbation of COPD, administer nebulized bronchodilators. B. Cardiogenic shock, administer positive pressure ventilation. C. Septic shock secondary to pneumonia, administer intravenous fluids. D. Diabetic ketoacidosis, administer insulin. Answer: C. Septic shock secondary to pneumonia, administer intravenous fluids. This patient presents with signs of infection, productive cough, fever 102.5 degrees Fahrenheit, leading to severe systemic compromise, confusion, hypotension 80/50 mmHg, tachycardia 120 BPM, tachypnea 28 BPM. This clinical picture is highly suggestive of septic shock, likely secondary to pneumonia given her respiratory symptoms and history of COPD. While an acute COPD exacerbation is possible, her severe hypotension and confusion point to a systemic infection. Cardiogenic shock would typically present with pulmonary edema, crackles, and possibly JVD, not necessarily fever and warm, dry skin in early stages. Diabetic ketoacidosis is less likely given the absence of typical DKA symptoms like Kussmaul respirations or fruity breath. The immediate priority in suspected septic shock is aggressive intravenous fluid resuscitation to restore perfusion and blood pressure, as patients are often profoundly hypovolemic due to vasodilation. For example, if you don't give fluids promptly, the patient's organs will suffer from lack of blood flow. Always prioritize fluid resuscitation in hypovolemic shock, including septic shock. Question 18. You are called to a motor vehicle accident where a car has collided with a tree. The 30-year-old unrestrained driver is trapped. He is conscious but confused, complaining of severe chest pain and difficulty breathing. You note significant crepitus over his sternum and paradoxical chest wall movement. His blood pressure is 90/60 mmHg, heart rate 120 bpm, respiratory rate 28 bpm, shallow. What is the most appropriate initial management for his chest injury? A. Place a tight bandage over the paradoxical segment to stabilize it. B. Initiate positive pressure ventilation with a BVM at a slow rate. C. Administer high-flow oxygen and consider positive pressure ventilation. D. Transport rapidly in a Trendelenburg position. Answer: C. Administer high-flow oxygen and consider positive pressure ventilation. This patient has a flail chest, indicated by significant crepitus over his sternum and paradoxical chest wall movement, which is compromising his breathing and potentially leading to respiratory failure and shock. The concept tested is the appropriate management of a flail chest. Placing a tight bandage is generally not recommended as it can impair ventilation and increase the risk of underlying pneumothorax. Transport in a Trendelenburg position is contraindicated for respiratory distress as it exacerbates breathing difficulty. The immediate priority is to support ventilation and oxygenation. While the patient is breathing, the shallow breaths and paradoxical movement indicate inadequate ventilation. High-flow oxygen is essential, and positive pressure ventilation, PPV, such as with a BVM or CPAP if available and appropriate, helps to stabilize the flail segment internally by maintaining positive pressure in the lungs, improving tidal volume and oxygenation. For example, PPV pushes the paradoxical segment out, allowing for more effective breathing. Always prioritize adequate oxygenation and ventilation in patients with chest wall injuries. Question 19. A 5-year-old child presents after a fall from a second-story window onto concrete. The child is unconscious, apneic, and pulseless. Your partner immediately begins high-quality chest compressions. What is the most critical intervention to address the likely cause of this child's cardiac arrest in the pre-hospital setting? A. Defibrillation. B. Airway management and ventilations. C. Administration of epinephrine. D. Rapid transport to the nearest trauma center. Answer: B. Airway management and ventilations. This question describes a pediatric traumatic arrest. The concept being tested is the understanding that in pediatric cardiac arrest, the most common cause is respiratory arrest followed by circulatory collapse, hypoxia and hypovolemia, rather than primary cardiac arrhythmias like in adults. Therefore, unlike adult cardiac arrest where defibrillation is often the initial priority for shockable rhythms, in a pediatric trauma arrest, the most critical intervention is addressing the airway and ventilation problems that led to the arrest. Effective airway management, oxygenation, and ventilation are paramount to reverse the underlying hypoxia and acidosis. Defibrillation is only appropriate if a shockable rhythm is identified, and epinephrine is a secondary medication. While rapid transport is important, immediate on-scene intervention to address the primary cause is crucial. For example, without effective ventilations, compressions alone will be less effective in a child whose heart stopped due to lack of oxygen. Always prioritize the A and B in the ABCs for pediatric trauma arrest. Question 20. You respond to a construction site where a 35-year-old male has sustained an electrical burn from a live wire. He is conscious but confused, and you note an entrance wound on his right hand and an exit wound on his left foot. His ECG shows multifocal premature ventricular contractions, PVCs. What is the most critical pre-hospital intervention following scene safety and stopping the electrical source? A. Apply ice packs to the burn wounds. B. Monitor for and manage cardiac dysrhythmias. C. Rapidly administer a large volume of 4 fluids. D. Cover the burn wounds with dry sterile dressings. Answer: B. Monitor for and manage cardiac dysrhythmias. This patient has sustained a significant electrical injury. The concept tested is the unique and life-threatening physiological effects of electrical current on the body, particularly the heart. The most critical concern with electrical injuries is their unpredictable effect on cardiac conduction, which can cause immediate or delayed dysrhythmias, including lethal ones like ventricular fibrillation. The multifocal PVCs are a warning sign of myocardial irritability. While 4 fluids, burn wound care, and pain management are important, the immediate life threat is cardiac. Applying ice can worsen tissue damage, and fluids are secondary to cardiac monitoring. For example, even if the patient appears stable initially, their heart can go into a lethal rhythm at any moment due to the electrical current's pathway through the body. Always prioritize continuous cardiac monitoring and be prepared to manage dysrhythmias in electrical burn patients. Question 21. A 28-year-old male presents with sudden onset of severe headache, described as the worst headache of my life. He is alert but agitated, complains of neck stiffness, and has photophobia. His vital signs are BP 150/90 mmHg, HR 80 bpm, RR 16 bpm, temp 99.0 degrees Fahrenheit 37.2 degrees Celsius. His pupils are equal and reactive. What is the most critical intervention in the pre-hospital setting for this patient? A. Administer analgesics immediately for pain relief. B. Perform a detailed neurological examination including motor and sensory function. C. Transport rapidly to a facility capable of neurosurgical intervention. D. Administer antiemetics for nausea if present. Answer: C. Transport rapidly to a facility capable of neurosurgical intervention. This patient's presentation, particularly the sudden onset of the worst headache of my life, combined with neck stiffness and photophobia, is highly suspicious for a subarachnoid hemorrhage, SAH, a type of hemorrhagic stroke. The concept tested is the recognition of a time-critical neurological emergency that requires definitive neurosurgical intervention. While pain relief, detailed assessment, and antiemetics are part of supportive care, none of them address the underlying life-threatening intracranial bleeding. Rapid transport to a facility with neurosurgical capabilities is paramount, as early diagnosis and intervention, e.g., coiling or clipping of an aneurysm, are crucial for patient outcome. For example, delaying transport could lead to rebleeding or increased intracranial pressure, severely worsening the prognosis. Always prioritize rapid transport for patients with suspected SAH. Question 22. You are called to a construction site for a 45-year-old male who has been working outdoors all day in 95 degrees Fahrenheit 35 degrees Celsius weather with high humidity. He is disoriented, has hot, dry skin, and is unconscious. His core body temperature is 105 degrees Fahrenheit 40.6 degrees Celsius. Which of the following is the most critical initial intervention? A. Administer oral rehydration solutions. B. Move the patient to a cooler environment and begin rapid active cooling. C. Apply warm blankets to prevent shivering. D. Administer hypertonic saline intravenously. Answer B. Move the patient to a cooler environment and begin rapid active cooling. This patient is suffering from classic heat stroke, indicated by exposure to extreme heat, altered mental status, disoriented, unconscious, hot, dry skin, and a core body temperature of 105 degrees Fahrenheit 40.6 degrees Celsius. The concept tested is the immediate life-saving management of heat stroke. Oral rehydration is inappropriate for an unconscious patient. Warm blankets are for hypothermia, not hyperthermia, and would worsen the condition. Hypertonic saline is not indicated for heat stroke. The most critical initial intervention is to immediately move the patient to a cooler environment and begin rapid active cooling measures, e.g., cold packs to neck, armpits, groin, misting with water and fanning, cold 4 fluids if authorized and available, to bring the core temperature down as quickly as possible. For example, every minute the patient remains hyperthermic, there is a risk of permanent organ damage. Always prioritize rapid cooling in suspected heat stroke. Question 23. A 6-month-old infant is found unresponsive, pale, and apneic by their parent. The parent reports the infant had a sudden episode of crying and turning blue before becoming unresponsive. On arrival, you note the infant is limp, pulseless, and apneic. You immediately begin CPR. Upon initial assessment, there are no signs of trauma. What is the most likely underlying cause of this infant's cardiac arrest in the absence of trauma? A. Sudden infant death syndrome, SIDS. B. Respiratory arrest. C. Cardiac arrhythmia. D. Aspiration of foreign body. Answer B. Respiratory arrest. This question tests the understanding of the most common cause of cardiac arrest in infants, especially in non-traumatic settings. The key clues are the infant's age, 6 months, the report of sudden episode of crying and turning blue, and the absence of trauma. While SIDS is a diagnosis of exclusion and foreign body aspiration is a possibility, the most common pathway to cardiac arrest in infants and young children is respiratory compromise leading to hypoxia, then bradycardia, and finally asystole. In this scenario, the turning blue indicates significant hypoxia prior to arrest. Primary cardiac arrhythmias are much less common as the initial cause of arrest in infants than in adults. For example, if an infant gets a severe respiratory infection or chokes, their heart will eventually stop due to lack of oxygen. Always assume a respiratory origin for non-traumatic pediatric cardiac arrest. Question 24. You are evaluating a 70-year-old male with a history of diabetes who presents with altered mental status. His skin is warm and dry, he is breathing deeply and rapidly, Kussmaul respirations, and you note a fruity odor on his breath. His blood glucose level is high on your glucometer. What is the most critical intervention for this patient beyond basic airway management and oxygen? A. Administer oral glucose. B. Administer 50% dextrose, D50, intravenously. C. Rapidly administer large volume intravenous fluids. D. Administer a rapid-acting insulin dose subcutaneously. Answer C. Rapidly administer large volume intravenous fluids. This patient is presenting with classic signs and symptoms of diabetic ketoacidosis, DKA altered mental status, warm/dry skin, Kussmaul respirations, fruity breath, and extremely high blood glucose, HI. The concept tested is the pre-hospital management of DKA. Oral glucose and D50 are for hypoglycemia, which is the opposite problem. While insulin is the definitive treatment, it's typically administered in the hospital setting. The most critical immediate pre-hospital intervention for DKA is aggressive intravenous fluid resuscitation. Patients in DKA are profoundly dehydrated due to osmotic diuresis caused by high glucose levels, and fluid replacement is essential to restore perfusion, correct electrolyte imbalances, and help lower blood glucose. For example, without sufficient fluid, the body cannot correct the severe dehydration and metabolic acidosis. Always prioritize fluid resuscitation in patients suspected of DKA. Question 25. A 25-year-old male is found unconscious in an alleyway. He has a medic alert bracelet indicating epilepsy. He is actively seizing, with tonic-clonic movements, frothing at the mouth, and urinary incontinence. His SpO2 is 85%. Which of the following is the most critical initial intervention? A. Administer oral glucose to rule out hypoglycemia. B. Restrain the patient to prevent injury. C. Protect the airway and ensure patient safety. D. Administer a benzodiazepine intravenously immediately. Answer: C. Protect the airway and ensure patient safety. This patient is experiencing an active generalized tonic-clonic seizure. The concept tested is the immediate and safe pre-hospital management of a seizing patient. While hypoglycemia can cause seizures, administering oral glucose to an unconscious, seizing patient is dangerous due to aspiration risk. Restraining a seizing patient is generally contraindicated as it can cause musculoskeletal injury to both the patient and provider. Administering a benzodiazepine, like midazolam or lorazepam, is appropriate for status epilepticus, prolonged or recurrent seizures, but the absolute most critical initial intervention is always protecting the patient's airway and ensuring their immediate safety. This includes moving objects away from the patient, placing them in a lateral recumbent position, if safe to do so, to protect the airway from secretions, and protecting their head. For example, simply rolling the patient onto their side can prevent aspiration and ensure adequate breathing. Always prioritize safety and airway protection in an actively seizing patient.